Picture this scenario. It is 4:00 p.m. on a Friday.
Oh, the classic Friday afternoon special.
Right. You are staring down the barrel of an incredibly packed clinical schedule, and you are already running 20 minutes behind.
Sounds like a typical week.
Yeah, exactly.
Hmm.
And sitting in exam room 3 is a 55-year-old patient with poorly controlled diabetes and a chronic non-healing foot ulcer.
Let me guess, you can probe it straight to the bone.
You can probe it straight to the bone. So based on the history, the inflammatory markers, the clinical presentation, your suspicion for chronic osteomyelitis is just sky high.
Right, you're practically certain it's there.
Exactly. But you were immediately faced with a very common yet remarkably complex diagnostic fork in the road. Down one path, you have the MRI.
Non-invasive, widely available.
Yeah, usually your best friend for a quick look under the hood. But then down the other path, you have the bone biopsy.
The definitive gold standard procedure.
Right, the only way to actually culture the bug. But it brings the very real reality of an invasive surgical intervention.
It is the clinical dilemma that keeps infectious disease specialists, orthopedists, and primary care clinicians awake at night. You know, you are constantly trying to walk this tightrope.
It really is a tightrope.
Yeah, because on one side, you want to spare your patient from unnecessary procedural discomfort, surgical risks, and, well, delayed wound healing.
Nobody wants to put a patient through a procedure they don't need.
Exactly. But on the other side, you face the absolute clinical necessity of getting an accurate, definitive diagnosis. Because if you don't, you end up empirically blasting them with broad-spectrum antibiotics for 6 weeks.
Which is an antibiotic stewardship nightmare.
Total nightmare. Choosing the wrong diagnostic path, or even choosing the right path at the wrong time, it can lead to disastrously delayed treatment, misdiagnosis, or just subjecting a patient to risks they didn't need to take.
And that is our exact mission for this discussion. In this deep dive, we're going to completely map out the optimal diagnostic pathway for suspected chronic osteomyelitis.
We really need to get into the weeds on this one.
We are going out into the weeds to clarify exactly where the blind spots of an MRI are hiding, and we are going to define the precise moments when you need to abandon that standard imaging approach and firmly decide that pulling the trigger on a bone biopsy is clinically imperative.
I like that. We want to equip you with a strategy that balances resource stewardship with uncompromised patient safety.
Right. And to do that effectively, we have to look past the basic flowcharts.
Yeah, I mean, this isn't just about what feels right intuitively. It is about deeply understanding the mechanical limitations and the physiological strengths of the tools at our disposal.
The reality of clinical practice requires us to constantly evaluate the specific context of the patient sitting in front of us.
Rather than just blindly following a rigid diagnostic algorithm.
Okay, let's unpack this by starting at the very beginning, the default pathway.
The MRI.
Right. For the vast majority of clinicians, the standard starting point when chronic osteomyelitis is suspected is putting in the order for an MRI.
Which makes perfect sense.
It does. Honestly, this approach feels completely natural. It aligns perfectly with clinical intuition. You want to get a look at the marrow, you want to see the extent of the soft tissue involvement, and you want to do it in a way that respects your patient's comfort.
It does feel natural, and there is a very sound physiological reason why MRI takes the lead as the initial diagnostic tool.
That's the sensitivity, right?
It all comes down to the sheer power of sensitivity. MRI provides incredibly detailed images of the bone marrow architecture and the surrounding soft tissues without a single scalpel blade.
Which is amazing technology when you think about it.
It really is. Because it is so highly sensitive to fluid and marrow edema, it is exceptional at detecting the early changes that suggest an infection.
Right, those early inflammatory markers in the tissue.
Exactly. In fact, if you get an MRI back and the marrow signal is completely clean, it is sensitive enough to effectively rule out chronic osteo right then and there.
Got the huge relief for the clinician.
Oh, absolutely. By utilizing this as your first step, you are potentially sparing a massive cohort of patients from the localized trauma, the risk of secondary infection, and just the general misery associated with a bone biopsy.
There really is no better feeling than getting that clean MRI report back on a Friday afternoon.
It lets you sleep on the weekend.
It really does. I want you, the listener, to think about your own clinical algorithms right now. Getting that clear scan gives you a moderate to high level of confidence to look at the patient and say, the bone is safe.
It is an excellent screening tool.
It is. But, and this is the massive caveat that we are going to dissect today, you have to remember that an MRI is merely the first step. It is a screening net, not the judge and jury.
That is the exact mindset you need. You start with the MRI to screen the suspected area non-invasively, but you cannot turn off your clinical vigilance.
You have to stay on your toes.
Right. You have to maintain a state of preparedness, knowing that you might need to escalate to a biopsy depending on what that initial MRI reveals, or honestly, what it completely fails to reveal.
Here's where it gets really interesting. We know MRI has incredible sensitivity. Think of it like a massive fine mesh fishing net that catches absolutely everything in the water.
I like that analogy.
But the primary limitation, the trap that is so easy to fall into, is that while it is highly sensitive, it is not perfectly specific.
Not even close in some cases.
Right. It catches the fish you're looking for, sure, but it also hauls up old boots, tires, and seaweed.
The specificity trap. It is arguably the single biggest hurdle in non-invasive diagnostics for bone infections.
Break that down for us. Why is the specificity such an issue?
Well, because MRI is exquisitely sensitive to any changes in tissue water content or marrow replacement, it can very easily suggest an infection when absolutely no infection is present.
Because it's just picking up fluid.
Exactly. It highlights areas of inflammation, post-operative fluid accumulation, or just reactive tissue alteration. But an MRI cannot definitively tell you the exact cellular or microbiological cause of those changes.
So it shows you there's a problem, but not what the problem is.
Right. A bright signal on a T2-weighted image just means there is fluid and inflammation. It doesn't tell you if that inflammation is from Staphylococcus aureus or just mechanical stress.
And this drop in specificity becomes a massive liability in complex clinical scenarios.
A huge liability.
Let's really drill down into those complex scenarios, because this is where the textbook meets the messy reality of patient care. The first major scenario that completely muddies the MRI waters involves hardware and implants.
Oh, hardware is a nightmare for MRI.
Picture a 40-year-old patient who had a severe motor vehicle accident 2 years ago. They have a massive intramedullary nail in their tibia.
Okay, I'm picturing it.
They come in with a dull ache and a slightly elevated CRP. If you throw them in an MRI scanner, the specificity of that scan just absolutely plummets, right?
It drops off a cliff. The presence of orthopedic hardware creates significant multifactorial challenges for MRI technology.
Starting with the physics problem, I imagine.
Right. First, you have the physical physics problem. The metal materials distort the magnetic field, creating massive susceptibility artifacts that completely obscure the surrounding bone and tissue.
So you just can't see anything.
You literally get a black hole on the image exactly where you most need to see.
But don't we have metal suppression sequencing now?
We do, but even with metal suppression sequencing, you run into the physiological problem. The very presence of an implant often causes a baseline level of localized inflammation, micromotion, and tissue alteration that the MRI will readily detect.
The body is just reacting to the metal.
Exactly. The scan will light up around the hardware. But trying to differentiate whether that signal is just the body's expected reaction to a giant piece of titanium, or if it represents a brewing biofilm-associated chronic osteomyelitis becomes nearly impossible.
You're just staring at a glowing white ring around the nail, shrugging your shoulders.
Exactly. The specificity is severely compromised. You know there is inflammation, but the MRI cannot definitively point the finger at a bacterial pathogen.
That makes perfect sense for metal. But what about the purely biological confounders? The next trap we need to look out for is the terrifying overlap between malignancy and infection.
This one is incredibly stressful for clinicians.
Right. As clinicians, we would love for a radiologist to give us a definitive answer between a tumor and a bone infection, but we have to remind ourselves that MRI simply cannot reliably distinguish between chronic osteomyelitis and a malignant process.
This is a critical point for patient safety. Both chronic infections and malignancies can present on an MRI with incredibly similar features.
Because they both cause tissue destruction.
Yes. They both cause significant changes to the bone marrow architecture. They both induce aggressive local inflammation, and they both destroy normal soft tissue boundaries and cortical bone.
So if you have an elderly patient with lytic lesions,
and you rely solely on the MRI to differentiate between a metastatic process and chronic osteomyelitis, you are running a very high risk of a catastrophic misdiagnosis.
that is a terrifying thought.
It is. Assuming an MRI can confidently tell the difference between these two distinct pathologies will inevitably lead to clinical errors. You need tissue.
Okay, and what happens when the bone is perfectly fine, but the tissue around it is an absolute disaster?
The bystander effect.
Right, that's the third scenario where the specificity trap really catches clinicians off guard. extensive soft tissue disease.
Right. Think back to your diabetic patient with the deep foot ulcer we talked about earlier, or someone with severe localized dermatitis or broad areas of tissue breakdown.
The inflammation is just everywhere.
The inflammation from that massive soft tissue disease cascades downward. It physically overlaps with the periosteum in the bone.
And the MRI sees all of that.
The MRI is going to pick up all of this extensive inflammatory change. The imaging picture becomes intensely confusing because the reactive marrow edema from the overlying soft tissue disease perfectly mimics the deeper marrow changes of actual osteomyelitis.
So the bone isn't actually infected?
The bone itself might not be infected at all. It is just angry because the neighborhood around it is on fire.
That is a great way to put it.
Again, the MRI is showing you that something is wrong, but its specificity drops too low to definitively confirm that the bone itself is infected.
Okay, so that brings us to the ultimate decision point. We know the default is MRI. We know all about the blind spots, the fishing net catch in the old boots, the metal artifacts, the tumors mimicking infections, and the cascading soft tissue inflammation.
The list goes on.
It does. So the crucial question is, when do we definitively deviate from that default pathway? When do we stop relying on the scanner and actually pull the trigger on a bone biopsy?
You pivot to a bone biopsy the moment the MRI fails to provide the clarity you need to safely and effectively treat your patient.
So when the picture is muddy.
Right. If the MRI results come back as inconclusive or equivocal, specifically because of those confounders we just discussed, like the tibial nail or the extensive soft tissue disease, bone biopsy steps in as the definitive standard.
Because you need to see the cells.
You need histopathological confirmation to see what is actually happening at the cellular level.
But I'm going to play devil's advocate here for a second.
Go for it.
A biopsy is invasive. It hurts. It introduces a needle into potentially sterile bone. If the MRI is a little murky, but I'm pretty sure it's an infection, why not just empirically treat? Why risk the biopsy just to look at tissue under a microscope?
Because it is rarely just about what the tissue looks like under a microscope. It is about what is actually growing in it.
The microbiology.
Yes. This is arguably the most critical trigger for a biopsy. If you are at a point in the clinical pathway where microbiological confirmation is needed to tailor specific antimicrobial therapy, a bone biopsy is completely non-negotiable.
Right, because an MRI cannot culture bacteria.
Exactly. You cannot send a JPEG to the microbiology lab.
That would be nice, but no.
If you need to identify the exact pathogen to guide targeted, effective treatment, you have to get bone. We are living in an era of terrifying antimicrobial resistance.
They really are.
You cannot just empirically treat a suspected chronic bone infection with 6 weeks of intravenous vancomycin and piperacillin tazobactam based on a fuzzy MRI.
It's just bad medicine.
It is. You need to know if you're fighting MRSA, Pseudomonas, or some indolent coagulous negative staph. To do that responsibly, you must obtain a definitive sample.
That is a stark reminder of our antibiotic stewardship duties. We also have to highlight the situations where we skip the MRI entirely, right?
Oh, definitely.
There are times when patient factors demand that we bypass the scanner and go straight to biopsy or alternative imaging.
We are talking about absolute contraindications to MRI.
Right. Patients with older, incompatible pacemakers, retained metallic shrapnel in dangerous locations, or patients with such severe claustrophobia that an MRI is physically impossible or unsafe to perform without deep sedation.
In these cases, attempting the default pathway is a complete non-starter.
You just go straight to the biopsy or nuclear medicine alternatives.
This raises an important question, however, about the bone biopsy itself. We constantly call it the definitive gold standard, but we need to be honest. It is not infallible.
Not at all.
Clinicians must be acutely aware of the false negative trap and the very real risk of sampling error.
Oh, the sampling error. This is incredibly frustrating for everyone involved.
I mean, it's the worst.
You do everything right. You convince the patient to get the invasive procedure. Interventional radiology drills the bone sample. You send it off. And 3 days later, the pathology and microbiology reports come back completely negative.
And you think you're done.
Right. You breathe a sigh of relief and think you are in the clear. But that is a massive trap.
It is a dangerous trap. Think about it like trying to find a single thin vein of gold by drilling a core sample into a mountain.
That's a great visual.
The infection in chronic osteomyelitis is not always uniformly distributed throughout the bone. It can be incredibly localized.
It can be patchy, right?
Very patchy. It hides in tiny necrotic sequestra. If the biopsy needle misses the exact nidus of the infection by even a millimeter, you are going to pull a beautiful sample of healthy, uninfected cancellous bone.
So you get a negative result while the infection continues to silently rage just a millimeter away.
Precisely. Therefore, if your bone biopsy is negative, but your clinical suspicion and the initial MRI presentation remain highly indicative of an infection, you cannot just drop the investigation and tell the patient they are fine.
You have to keep pushing.
You must be prepared to repeat the biopsy, perhaps with better image guidance, or aggressively explore other diagnostic options. You cannot let a single negative biopsy overrule a screamingly obvious clinical and radiological presentation.
That is such a vital piece of the puzzle. It really emphasizes that this diagnostic algorithm isn't a simple, mindless flowchart.
You can't just follow the arrows.
You have to constantly tailor your approach to the specific patient sitting in front of you. And speaking of tailoring the approach, we need to address some nuanced populations where the standard rules bend quite a bit.
This is where clinical judgment really gets tested.
Let's talk about diabetic foot osteomyelitis, or DFO.
DFO requires highly tailored clinical judgment. In this specific population, the specificity of an MRI varies wildly.
Because of the neuropathy and structural changes?
Exactly. The underlying biomechanical changes, the Charcot neuroarthropathy, the altered weight bearing, the microvascular ischemia, all of these alternative pathologies associated with the diabetic foot make MRI interpretation exceptionally challenging.
Because the Charcot foot looks terrible on an MRI.
An MRI of an acute Charcot foot can look identical to a raging osteomyelitis. Because of this varying specificity, the clinical context of a diabetic foot ulcer might actually prompt a clinician to bypass a prolonged MRI debate and move toward a bone biopsy much earlier in the diagnostic pathway than they would for, say, a healthy athlete with a suspected tibial infection.
That makes a lot of sense. What about pediatric patients? Kids aren't just tiny adults, and their bones behave very differently.
Absolutely. When dealing with pediatric patients, the evidence guiding the MRI versus biopsy decision is far less uniform.
Why is that?
The pathophysiology of bone infections differs significantly in children, largely due to their open growth plates and different intraosseous vascular anatomy.
Right, the blood supply to the bone changes as we age.
It does. And the pathways that work reliably in adults simply do not translate directly to pediatric care. Clinicians must adjust their strategies based on specialized pediatric guidelines and a much more nuanced clinical judgment.
Which often means heavily relying on pediatric orthopedic specialists.
You definitely want them on your team.
Okay, we've covered the default pathway, the specificity traps, the pivot points, and the special populations. Now let's talk about the pitfalls, the things you absolutely must avoid when navigating suspected chronic osteomyelitis.
The do not list.
Yes, the do not list. For instance, I see clinicians sometimes applying these chronic algorithms to acute situations.
Yes, that is a major misstep. You cannot apply chronic osteomyelitis diagnostic strategies to acute osteomyelitis or systemic sepsis.
They are completely different animals.
Entirely different clinical entities. Acute osteo, especially in kids or septic patients, is a fast-moving, destructive process with immediate systemic risk.
You don't have time for a slow workup.
Right. The slow, methodical, stepwise approach of getting an outpatient MRI and eventually scheduling a biopsy is for chronic, indolent presentations. Acute infections require distinct triage, blood cultures, and rapid diagnostic speed.
Right. And on the flip side of that, you shouldn't just biopsy everyone.
Please don't.
If the clinical picture is straightforward, the MRI is unequivocally clear, and targeted microbiology isn't strictly required for initial management, say, an uncomplicated case where empiric therapy is deemed safe and appropriate, you need to respect the procedural risks of a biopsy and hold off.
Resource stewardship and patient safety demand that we do not perform invasive procedures unnecessarily.
It's all about balance.
If the non-invasive tool provides the necessary clarity and you don't absolutely need the culture data to proceed safely, we stop there. The MRI is a piece of the puzzle, but when it gives you the whole picture clearly, trust it.
I also want to touch on something I've been seeing a lot of chatter about lately in the journals, AI and radiomics models.
Ah, the future of imaging.
I know some clinicians are hoping these algorithms will just solve the MRI specificity problem for us entirely. Should we be relying on these yet?
Not yet. Radiomics is a fascinating field. It uses machine learning to extract massive amounts of quantitative pixel data from MRI scans that the human eye simply cannot see.
Looking for patterns we miss.
Yes. The hope is that these models can detect the subtle microscopic differences between, say, tumor edema and infection edema.
Which would be incredible.
It would change everything. But currently, these are largely unvalidated radiomics models. The technology is promising and constantly evolving, but until these numerical thresholds and AI models are robustly validated in large, multi-center clinical trials, we cannot depend on them to make critical, limb-saving diagnostic decisions.
We have to rely on established clinical evidence for now.
Exactly.
Okay, so bringing this all together, if we look at the entire landscape, the MRI screening, the biopsy triggers, the confounders, the special populations.
If we connect this to the bigger picture, all of these details, the traps, and the exceptions distill down to a single guiding synthesis.
Let's hear the golden rule.
Here's the golden rule to anchor your clinical practice. Start with an MRI to non-invasively assess and potentially rule out suspected chronic osteomyelitis.
That's step one.
But boldly and decisively reserve bone biopsy for inconclusive MRIs, complex clinical scenarios with limited MRI specificity like hardware or Charcot-Foot, or whenever microbiological confirmation is absolutely essential to tailor safe, effective antimicrobial treatment.
That sums it up perfectly. So what does this all mean for you tomorrow in the clinic when that 4:00 p.m. patient is sitting on the exam table?
It means you have a plan.
You do. But I want to leave you with a final, somewhat provocative thought to mull over. We have spent this entire time meticulously detailing the diagnostic superiority of one test over another in highly specific situations. We've debated the merits of the scanner versus the needle. But here's the fascinating, somewhat humbling reality of our profession. Despite all of our advanced diagnostic technology, when we look at the available evidence, we actually cannot confidently say that choosing MRI or choosing biopsy alone definitively improves long-term infection resolution or overall patient outcomes.
It's true, there is no magic bullet test that guarantees the bone will heal.
Exactly. And furthermore, there are no perfectly validated numeric thresholds to completely automate these decisions for us.
The AI isn't ready to take over yet.
No, it's not. It really highlights the ongoing, unautomatable art of medicine. It tells us that ultimate clinical success doesn't just rely on picking the right initial diagnostic test from a menu.
That's just the starting line.
Right. It relies on taking that imperfect data, initiating a plan, and then closely, obsessively monitoring the patient's actual clinical response. It's about expertly adjusting the treatment plan along the way when the wound doesn't heal or the markers don't drop, choosing the MRI or the biopsy. That's just the very beginning of the work.